Yeah. It's made by the Switzerland and one of the Japanese
Yes. Oh,
and
really?
yeah, one from the Singapore. Yeah,
Hmm.
he discussed successful management of the unstable trochanteric fracture,
Trochanteric fracture.
mainly upon the PFNA. Yeah,
PFNA. Okay,
yeah,
Switzerland. Maybe Switzerland.
yeah.
Yes, yes. How was it?
Sorry.
How was it? Interesting?
Yes, very
Yes,
interesting.
yes, yes.
But they discuss uh, uh, about the augmentation.
Augmentation.
Augmentation, especially for the osteoporotic patient.
Yes, yes.
They put
Maybe
the cement into the blades.
cement.
Blade.
Cementing. In the
Yeah, cement,
cement
yes,
through, yeah,
cement.
through the lug screw.
Yes.
Yeah.
No, not
Okay.
the last screw. That's a plate of the
Blade,
PFNA.
blade,
Blade.
blade,
Yeah.
blade. Oh,
There is a
PFS.
small hole. Yeah.
Oh, there's a
Small
small
hole
hole.
at the tip of the
Okay,
blade.
okay,
Helical,
okay.
helical
Oh,
blade. Yeah.
yeah, I know.
Yeah.
It's a very good
But
idea because
yeah,
many other patient has very osteoporotic
yeah,
patient. Yes, yes. It's
yeah,
a good idea. And
yeah.
maybe in the next talk, I will talk about the trochanteric fracture
Hmm.
fixed by the blade. Blade.
Yeah.
My idea is same. So blade is very effective
Yeah.
rather than the screw
Hmm.
because blade we can insert without a reaming. After
Mm.
the reaming, most of bone is removed due to the reaming.
Yeah.
Instead of the reaming and the removal, so insert the blade in a
Mm.
compressed bone
Yeah.
around the blade. It's
Hmm.
quite effective. Of
Mm.
course, the cement is very good tool to fix for the
Yeah.
osteoporotic bone, but I think so. Most patient is insert the blade is enough because
Mm.
if we insert the blade, the bone is compressed around the blade. It can stabilize the fixation of the blade.
Yeah.
Okay.
Okay.
This idea is similar for me.
Yeah.
Anyway, I will continue to talk about dual AC screw.
Yeah.
So this is start from this one, a vascular necrosis.
Yeah.
After the dual AC screw, a vascular necrosis is very quite rare because maybe I don't know the reason, but because of the very good stability of the bone, only 3.7%. But if once it occurs, most patients needs arthroplasty, such as hemi arthroplasty or total hip arthroplasty. Only one hip can be treated conservatively. This is a serious problem after the subtrochanteric, after the fixation of the femoral fracture. It's a subtrochanteric fracture. So I experienced only 3 hips. In addition, this fracture is concentrated to the very limited period by the one surgeon. Maybe it is due to the technical error because, as you know, after the CHS or DHS, so trochanteric fracture is very rare. So due to this plate, this uh, plate can uh, this plate the stress. After the pinning or screwing, most stress is concentrated to here, the most distal pin. So we can avoid this concentration using the side plate. Yes, like this. Oh, this is a very, very impressive face. It is broken at the distal end of the screw. Maybe it is very important to fix this distal screw, cortical screw. So most distal screw never fixed too tight. Too tight should be avoided because this is only the stabilize the plate on the bone. If we seat the plate and fix the screw too securely, too tightly, it can cause some contradiction of the shape of this plate and the angle of this insertion. It can cause some mechanical stress. So it is the same after the IM nail. After the IM nail, we also use the transverse screw. But it should be stopped, the screwing. Just the screw head attached to the cortex. After that, if we drive the screw head can break the cortical bone. It can cause the fracture. At the beginning of gamma nail insertions usage, maybe the 1990s, fracture after the gamma nail is very frequent. Maybe it is due to the improper fixation technique of the distal interlocking screw. It is similar. So if you drive the screw after the touch to this plate, the femoral head, the screw head should be stopped. If you drive more, it can cause a fracture in some cases, like this. So it is, I experienced the two cases of extraosseous insertion. One is displaced and another is undisplaced case, like this. Like this. Another is like this. But unfortunately, two cases went very well. Because this fixation is very, very good fixation to stabilize and prevent the various displacement of the femoral head. And sorry, in Japanese, this is a result of clinical result of the patient. We can follow more than 2 years. Around 60% patient can walk independently with or without cane. So most all patients are united and event-free. Okay, next I want to talk about the morphology of the femoral neck. I think the morphology of the femoral neck is very interesting. It is not simple as we think. It's quite interesting and complex shape. So basically, how to evaluate the femoral neck anteversion? It is quite a difficult question. Classically, the one very old Japanese doctor proposed the Kai method. So it is calculated by the AP and lateral view using geometric equation calculation. It is quite difficult. It is around 30 years ago when I was a fellow of the junior resident in the orthopedic. My supervisor ordered me to calculate the patient antibody using the X-ray, the AP and the lateral view. So I calculated using the calculator, using triangular mathematics. It was very difficult. But now we can use CT scan. So using a CT scan, we can easily calculate the femoral anteversion, the angle between the femoral neck axis and the posterior condylar axis. But it needs the long CT from the femoral head to the knee. So radiation exposure is very big. So normally, for the femoral hip fracture, femoral neck fracture, is the only even we order the CT scan, only the upper half of the femur. Normally, we never order to the full length of the femur. So, how to calculate, evaluate the anteversion? Because anteversion is very important, especially for the fix of the trochanteric fracture. So I come up with use the linear aspera as a standard of the rotation. So this is a linear aspera with the most posterior side of the femoral bone. So we easily identify this one, and I calculated the center of the femoral bone, and this angle, this linear aspera, this is the neck axis. This is the axis of the femoral neck, and calculated this angle using the CT scan. And interestingly, there is significant difference between the healthy side and fracture side. Most fracture reduce their anteversion. This calculation is unusual. Normally, we calculate the anteversion from the horizontal plane to the femoral neck plane. But using the linear aspera, this is direct to the most posterior side. So this angle is wider than we think. So, or maybe you subtract this angle from the around 90 degrees, so it can show the normal anteversion angle. So it is equivalent to the around 30 degrees of anteversion. This is a little bit later version. So because most after the trochanteric fracture and the femoral neck fracture, most of femoral bone reduce their anteversion. Maybe this is due to the cause of the cause of mechanism of fracture, cause of fracture. Most patients have fall down on his buttock. Then at this situation is femoral neck is here and the body weight is here. So body anteversion will be reduced or disappeared or even the lateral version due to the body weight. So in the average of around 50 degrees or 45 degrees lateral version compared to the healthy side. After the post-operatively, the most femoral head is reduced near the healthy side, but not completely. Even in average of, sorry, someone is coming. Oh, Chanta, okay. Okay. In average of 7 degrees is still in the lack of anteversion compared to the healthy side. So we need to reduct more because femoral head anteversion is affect to the walking side. If femoral head anteversion is reduced, maybe the leg will externally rotate during the walk. So in addition to the secure fixation, we need to consider about the anteversion of the femoral head for fix. to fix the trochanteric fracture. Okay, but it still needs the CT scan. Maybe it is in Japan. It's quite easy to order CT and MRI. It is, I think it is a very, very limited situation. In most countries, to take a CT and MRI is very, very difficult and quite expensive. But in Japan, interestingly, we need no cost to take the CT scan during the patient in the hospital, because during the hospitalization, during the stay in the hospital for this patient, the all cost is the same. All cost is included at the same price. So if we order the CT scan, if we order the MRI scan, if we order the blood examination, the total cost is same. So if we order the CT scan after the operation during the patient hospital stay, the patient don't have to pay the additional cost because all cost is included. So it is a very special situation. In addition, many Japanese makers manufacture the CT and the MRI machine. So every hospital has their own CT scan and MRI. So we can easily use the CT scan, but I think it is quite a limited situation. Oh, this is the defined method to evaluate the femoral antebiome. It also uses the CT scan. So this is the PCR, this is the femoral net axis. To compare the two angles, so we can easily calculate the femoral neck antebiome. So this is provided by the Dr. Weiner. It is 1975. But many studies have shown that their method tend to be underestimated. The one reason is neck axis is buried among the patient. And the bottom of the posterior condyle not always appear in the single size CT. Sometimes the bottom of the posterior condyle is appears in the different slices. But most important reason is that. Sorry, this is also Japanese. Femoral neck is not straight. It's bent posteriorly. This is the axial size of the femoral head. This is the femoral shaft center. This is the femoral head center. This is the femoral neck center. So these relationships comes like this. This one, if we draw a line from the femoral shaft center to the femoral head center, the femoral neck center comes anteriorly to this line. And if we draw the line from the femoral shaft center to the femoral neck center, so this line comes anteriorly than the femoral head center. So it is quite important. The femoral shaft center and the femoral neck center and the femoral head center never come in the same line. It has some bowing, anterior bowing around the 12 degrees in average. Some patient is 0, completely straight. Some patient has more than 30 degrees. This is quite different among the patients. So if we draw the line from here, shaft center to the head center, maybe this point, this line come around 10% posterior of the total length, total width of the femoral head, femoral neck. from the center of the femoral head. So, and if we draw the line from here to the from shaft center to the neck center, it comes around 20% anterior from the femoral head center. It means it is very important to during we use the IM nail from the center of the femoral shaft to the center of the femoral head. It always passes to the posterior within the femoral neck. It is very important findings. So some surgeons worry about it pass the posterior within the femoral neck, but I believe it is a normal. In the most patients have the shape of the femoral neck like this, anterior bowing. So it is quite natural if you insert lag screw from the center of the femoral shaft, where the shaft of the IM nail is placed, and from the center of the femoral axis, shaft axis, insert at the center of the femoral head. It always passes posterior to the femoral head. It is quite important finding. And another, this is always reported by another Japanese doctor. Femoral neck axis and the femoral shaft axis never come. It goes the different way. So it is very important. So we should understand this relationship between the femoral shaft and the femoral neck and the femoral head. So otherwise, we can confuse during the operation. So it is virtually impossible to insert the lag screw from the center of the femoral shaft through the center of the femoral neck and to the center of the femoral head. It is impossible anatomically. So if we, as I say, if you consider that this line is the axis of the femoral head, it should come to the anterior to the femoral shaft, because femoral neck always bent anteriorly. So this line comes anterior to the femoral shaft. Eventually, this angle is virtually similar to the PCA, posterior condyle line. So it can be underestimated to the antebiome. So like this. This picture clearly shows the relationship of femoral neck and femoral shaft. So if we, the pathway of the lag screw is here in the center of the femoral shaft and to the center of the femoral head. But actually, axis of the femoral neck is here, directly the anterior to the femoral shaft. So we should take into account this relationship during the operation. So this is a very good way to evaluate the antebiome. This is a body-height body method, anterior posterior view from the back to the front, abducting the patient leg around 30 degrees, and take the X-ray. Then we can get this image like this. So on this image, we can calculate the antebiome very easily. The line, the angle between this line. This line is the femoral neck axis from the femoral head center to the femoral neck center. draw the line, and again draw the line, the posterior condyle. Then we can calculate and estimate the antivirgin angle very, very precisely. So this is the relationship of the between this angle and angle between calculated on the CT. It's a very excellent relationship. So without a CT scan, we can exactly calculate the antivirgin. So using the single X-ray. This is quite interesting method. So in fact, this one is reported by Dr. Lee. Then we evaluated Dr. Lee evaluated this angle after the arthroplasty. Because after the arthroplasty, we can easily identify the head of the femoral head and the center of the femoral neck. But after that, we calculated on the normal hip, using the normal hip and calculated this angle and proved that it is also effective, not only after the operation, but also the pre-operative. This one. I was a co-author of this paper and calculated this angle and this angle using the draw the line from here and draw the line from here. Again, this relationship is very close. Around the correlation coefficient was around 0.96, virtually perfect. So if you master this technique, you can easily evaluate it, estimate the antivirgin very, very precisely. It don't need any cost, no radiation, only the single X-ray. But it requires a special technique to take the X-ray. So radiologist, radiographic technician need to master how to adjust the condition of the exposure. But it is quite easy. And after the several cases, they can get very, very good X-ray to calculate the antivirgin. In addition, this is only the sitting position. Like this, sitting and from the posterior to the anterior. But it cannot achieved just after the operation, the patient on the bed, or pre-operatively, just after the operation. To evaluate for the patient, just after the trauma and just after the operation, we take the similar X-ray on the supine position. It is quite easy. So we can do this technique. We can apply this technique all patients because the patient is only rest on the bed and abduct and flexion and abduct at around 30 degrees. So again, we can calculate the antivirgin quite easily. So in our hostel, we already confirmed the preciseness of this method, both preoperatively and after the operation. So if you're interested in this X-ray technique, please do your country. It's very, very useful. It is very, very economical. But it needs some technique to take the X-ray. Just it. This is the correlation between the CT scan and supine. We call it the Budin method. Budin method. It is quite classical paper, maybe around the 1970s. Then normally this is device for the hip for the child. So we can easily find the paper, original paper, but the doctor modified this technique for the adult. Then we modify this method for the supine position. It's quite useful. So the relationship between the Boolean method and CT is very close, around 0.7 in the correlation coefficient. And again, CT scan tend to underestimate the anteversion. Maybe I believe this method, this technique is more accurate than CT scan. So CT scan is very difficult to evaluate to decide the femoral neck axis. It is quite difficult. So we need to reconstruct the three-dimensionally. So to the three-dimensionally, we should reconstruct the shape of the femoral head and then decide the center axis of the femoral head. But using this method, we can easily identify the femoral neck axis and knee axis, posterior condyle axis quite easily. So it is very, very useful. Okay, so I compare to the patient after the trochanteric fracture. So in Japan, as I said yesterday or day before yesterday, in Japan, hip fracture is very, very common, very frequent. So in the fracture society, so many hip fracture sessions. So many surgeons precisely, accurately evaluate the study the before and the after the trochanteric fracture. The many surgeons focus on the status of reduction. So many surgeons prefer to classify the postoperative X-ray into three categories. One is the extramedullary and anatomical and intramedullary. That means we are focused on the relationship of the anterior cortex. If anterior cortex of the femoral neck is come to the anterior cortex of the shaft, maybe it can cause the touch or the impinge of two fragments. Then after that, so one fragment is stabilized. The excessive sliding and shortening never occur. And anatomical reduction as well. So anatomical reduction means for the anterior cortex, for the shaft anterior cortex or the neck come to the same line. It is also stable reduction. But unstable reduction is intramedullary. So in the intramedullary type, in the anterior cortex of the shaft like this, and the anterior cortex of the neck like this, and both fragments never come together. Then proximal fragment, neck fragment come under beneath the anterior cortex of the shaft. The sliding is never controlled. So it can cause excessive sliding and shortening of the femoral neck, and even the non-union. So with because of lack of bone contact. So so this type is, so many surgeons in Japanese surgery consider this reduction status is quite important. So interestingly, if you reduce extramedullary affected side, anteversion is very small, even the lateral version, because it is quite understandable. If femoral shaft is here, the femoral neck here is with the anteversion, but if reduce the extramedullary, so femoral neck like this, eventually femoral head is anteversion of the femoral neck is reduced. The anatomical reduction, both sides, the angle is anteversion is similar. And the intramedullary like this, is anterior side anteversion is larger than the unoperated side. So it is very quite interesting, very interesting. Okay, so in addition, the anteversion is different according to the slice level. The upper slice tend to reduce calculated as the smaller anteversion, and the lower slice increase anteversion. So it is also very interesting. So the morphology is very, very complex. So we should take into account. The one thing is the femoral neck is bent anteriorly. And we should consider taking into account the femoral neck anteversion after the internal fixation of the trochanteric fracture. So it is quite difficult to evaluate the anteversion even we use the CT scan, but using the Boolean view, we can easily evaluate the anteversion. So if you're interested in this method, please try in the next patient. Okay. It's finished. It's all.
Yeah, very interesting.
Interesting. Okay, thank you.
Yeah.
So
Yeah.
please try. It's very interesting and very easy to do. So please focus on, look carefully the anteversion, because it can affect the patient, the walking appearance. So if the patient after the operation, the anteversion is not enough, the patient tend to walk with external rotated leg. The knee face